Hello, dear all. So, in this discussion, let's understand the clinical assessment of miasm. So, how to find the miasm in the clinical cases. So, let's start. So, understanding of miasm, we have two types of miasms, that is dominant miasm and fundamental miasm. Dominant miasm is the currently the patient's clinical stage is available to us as physician. So what is the underlying miasm? That is called as dominant miasm. That is current stage of the totality of the symptoms with respect to the pathology. So that is the dominant miasm. How to find out the dominant miasm? By study of structure, form, function, thrown, which is available to the physician through totality of symptoms. So, dominant miasm, we study totality of symptoms, then we study pathology, whether the functional or structural. What is the onset, duration, progress of the disease over time? So even it is the onset is say 5 years, onset is say 1 month or 2 years or from 20 years. We study the onset. So whether it is slow onset, gradual progress, what is the progress of the pathology, and most important across the time plane, and of course which function affected, which system is affected, that everything we have to study for finding out the underlying miasm, which is called as dominant miasm, by study of structure, that is pathology affected, form thrown, that is totality of symptoms, and function affected, that is which system is affected and to what extent. So dominant miasm, this is how we study the structure, that is pathology, form thrown, that is totality of symptoms, function affected, say respiratory system affected, gastrointestinal system affected, and what is the extent of the system affected. So one patient of respiratory system may complain of the yellow discharge from nose. Another may have tonsillitis attacks. Third patient may have pleural effusion. So, what is the pathology developed and what is the function affected? So, you have to correlate both the things here and understand that if function affected is only that there is breathlessness, or if it is severe breathlessness, or patient is not having any breathlessness at all, or otherwise patient is having blocked nose or he is not having any blocked nose. So accordingly various types of symptoms will be present in the patient. So what is the function affected and to what extent? So if patient complains of gastrointestinal system uh, affection, say he is having acidity, so just burning in the epigastrium, or he is also having pain in the epigastrium. So how much is the digestion function affected? That you will have to consider and study it in depth to understand the pathology which is there underlying the all these symptoms of the disease. So just patient having flatulence, it indicates the functional pathology, but he is having pain in the epigastrium, burning in the epigastrium, or even sometimes he is having hematemesis. This indicates grave pathology. So always correlate pathology, that is structure and function and form. So they are all uh, connected together in these links. But for our study, we divide this in structure, form, function to study in depth what is the extent of disease and across time, and also find out the intensity and frequency of these sufferings of the patient. Second aspect of the miasm is the fundamental miasm, that is preload, also called as the past history and family history. So, what is the load with which the patient is born? It indicates the various diseases he has suffered in the past and also what is the family history. So, if family history is having diabetes, malignancies, it indicates the load of syphilitic miasm. If family history is of renal calculus, asthma, it indicates the preload of psychotic miasm. If past history patient suffered from pneumonias, tuberculosis, it indicates the patient is having the load of tubercular miasm on his system. So dominant miasm is the, I told you, it is present currently, today. So functional pathology indicates SORA. Irreversible pathology indicates syphilis. Any overgrowths are present, it indicates psychosis. Glands affection indicates tubercular miasm. Always treat the dominant miasm first. So patient presents with functional pathology. So whatever clinical symptoms patient is presenting, we have to assess whether pathology is functional or structural. That is, if it is superficial pathology or it is going in depth. In the other system of medicine, we label this pathology as disease diagnosis. For our study in homeopathy, we assess the pathology in terms of function and structure, in terms of reversible pathology or irreversible pathology. So, if it is irreversible pathology, it indicates syphilitic miasm. If there are overgrowths, it indicates psychotic miasm. Patient having glandular tendency, affections, that is the glands are enlarged, they are involved, say tonsillar glands are involved, it indicates tubercular miasm. And the instruction to the physician is always treat the dominant miasm. So what are the remedies which are corresponding to the dominant miasm? For Sora, it is sulfur and sorinum. For psychosis, it is thuja and medorinum. For syphilitis, it is syphilinum and also merxol. For tubercular miasm, it indicates the tuberculinum remedy. So the miasm which is underlying is called as dominant miasm and it points out to the remedies also. So this is a guideline for the physician that if the symptoms in the totality are only of the underlying miasm, then you can start the treatment with the anti-miasmatic remedy. So all these remedies are called as here anti-miasmatic remedy. If you are prescribing sulfur on totality of symptoms, whatever, it may be called as the constitutional remedy. So just for our understanding of the case and physicians understanding that whatever I am treating, I am administrating the remedy accordingly. Whether I am giving the remedy sulfur as constitutional or I am giving the remedy sulfur as anti-miasmatic, it should be clear in the physician's mind. Another guideline is to understand the miasm is by study of physical constitutions. So pyramidal shape of face, it is Sora. Round face, obese, pot-bellied structure of the patient indicates psychotic miasm. Dull, gloomy, prematurely old face indicate syphilitic miasm, whereas tall, lean, thin structure indicates tubercular miasm. So this is the picture representing soric face, pyramidal shape. This is psychotic, obese patient. This is syphilitic, sad, gloomy, depressed patients. This is tubercular, with the multiple, crowding of teeth, glandular affections. Another guideline is study the stage of pathology. First stage of inflammation, it is considered as psoriatic pathology. Second stage of inflammation is considered as psychotic miasm. Third stage of inflammation is considered as syphilitic miasm. So first stage of inflammation, psoriatic miasm, it is represented as functional pathology, always there in psora. So structural affections, we do not correlate with psoriatic miasm. Second stage of inflammation, it's psychotic miasm. So what is the understanding of second stage of inflammation? It means infiltrations of cells, edema, hypertrophy, tumors, indicates psychotic miasm. What is the meaning of third stage of inflammation correlated with syphilitic miasm? It means destruction, ulcerations. Another guideline to understand the miasm is by location, also called as sphere of action. So, skin and mucous membrane, if it is affected, indicates psoriatic miasm grossly. Again, just affection of skin does not correlate only psoriatic miasm. We have to study the pathology also. So, it is a three-dimensional study of totality of symptoms to understand what is the function affected, what is the pathology which is present, and across how much time the patient is suffering, and what is the clinical presentation, that is the form thrown. So, tissue hypertrophy, retentions, stasis, edema, overgrowths, tumors, warts, they indicate psychotic miasm. Affection of blood, bones, brain, heart, and destructive pathology indicates syphilitic miasm. Glands, respiratory system, affection of blood indicates tubercular miasm. So pathology like of the blood means anemia, leukemia, and glandular affections. Respiratory system affections with tuberculosis indicates tubercular miasm. So, other guidelines, nosological diagnosis does not indicate miasm. So, example TB. TB is not always tubercular miasm. You have to consider what is the form thrown. If patient comes with pleural effusion and having the infection of tuberculosis, it indicates psychotic miasm. If patient considers and comes with the hemoptysis, it indicates tubercular miasm. And only Ghone's focus is there, it may indicate to psoriatic miasm. There is destruction, fibrosis of lungs, it indicates syphilitic miasm. So ultimately, you must pay your attention on the pathology. Pathology determines the miasm, not the nosological diagnosis of the pathology determines miasm. Okay, so just we label the disease and correlate with miasm is not correct. Other guidelines of modalities, cravings, aversions, which correlate with miasms are aggravation during day, standing, and better with normal discharges is psoriatic miasm. Aggravation, night, damp weather, better by abnormal discharges. Say abnormal discharges means say better with ulcerative discharge, better with otitis media. It indicates psychotic miasm. Aggravation night, aggravation cold air, better by abnormal discharges indicates syphilitic miasm. So ulcerations comes under syphilitic miasm and a discharge will be ameliorating the patient, and pathology it indicates syphilitic miasm. So just have a line of differentiation with the types of discharge and a pathology. Craving hot food with psoriatic miasm. Craving for meat is tubercular miasm. So, what are the general guidelines to assess the miasm? Miasms are at the root of pathology. It is a soil, it is a foundation. Cure is possible by administration of anti-miasmatic remedy. Physician can predict the progress of disease by study of miasms. Thank you.